Good morning. I want to thank Jerry and the Planning Committee for inviting us today. It is, in fact, the first time this person who is introduced as John, and I'll call him Jack, and I have presented together. Though the conversations about mental health and school safety have been around our dining tables for as long as I can remember. Our focus today is children at the heart of the matter. I want to introduce my brother to you. In addition to being a child psychiatrist, he is someone who has worked on the periphery of educational systems and children's issues for his entire career. He's been a consultant to Parsons Child and Family Center and the Neil Hellman School, to Prospect School, Schenectady, Warren, and Washington County DDS and CPS, multiple CSEs, Warren County Head Start, and multiple family courts. Next, this is unfamiliar to me as an educator, but in the medical world, when you're presenting, you need to say, no financial disclosure or conflict of interest is present in our presentation today. I am currently director of the Hochbrunn Center. It is called the Dawn Lafferty Hochbrunn Center because Dawn's children's names are Lafferty. And so we're working with the family, and so they didn't want it to be just the Dawn Hochbrunn Center. They wanted their identity associated with it also, and so it is the Dawn Lafferty Hochbrunn Center. I'm currently associate professor also in the SAGE doctoral program in Ed Leadership, and that is in fact important today because it's how Dawn came into my life. And once upon a time, seems now long ago, I was district superintendent also at Westar 3. In interest of transparency, we decided that we should start this morning with revealing to you the perspective that we're going to bring. And the first of those is to share with you our beginnings. We attended school in Wilton when Wilton was a crossroads before it became suburbia. We went to a two-room school. In my class, there were 6 students. Jack, in yours?
There were 5.
In one classroom, there were grades K1 and 2. We sat in learning centers by grade. But really, we were in a classroom more than we were in a grade. The other classroom, obviously, was 3, 4, 5, and then we went off to the big school. But we come to you today as products of and proponents of rural schools and the value that they add to the lives of the children who are there. We also share with you our concern about the lack of sustainable models that bring together mental health and school safety. There have been remarkable programs that we have seen through our careers, but they have not been sustainable, and they have not resulted in systemic change. And we also share with you this bias. Jerry mentioned Common Core and APPR and accountability and all of the focus around that now. But our bias is this. If we think about boundaries, walls, and traditions, right now they're collapsing. And in that, there is a great deal of disorientation occurring and a great deal of opportunity. So this is the perspective with which we enter this conversation. As we began preparing for today, we really started thinking about the systems and the children. So we're going to look at the system first. That's you, Jay.
Chronically mentally ill. However, this never really got off the ground. There were several that were established, but the full number was never put together, and of course the financial commitments never came to be, deterred by the assassination and deterred by wars. And so in the ensuing 2 decades, we came to have what was called deinstitutionalization, which came to rely not upon the services of what was supposed to be happening through the community mental health centers, but relied solely pretty much on the use of medications. And so we had people moving quickly out of hospitals and needing care in the community. And so we came then to the 1990s, and that point, managed care commenced. And so we had two forces. Number one, shrinking the number of mental health beds in care. And then managed care imposes sort of a top-down system in which there is restrictions on the length of stay. And so the length of stay comes to be 5 to 7 days. And more recently, we've contested with that even with children's treatment. And so we come to the year 2000, and at this point, we now have 2 million people incarcerated in the prisons in the United States. And to put that in some perspective, the population of the state of Vermont is 626,000. So we have 3 times the number of people incarcerated who live in the entire state. We have within the populations of prisons at least 1/3 who have major mental health problems, and at least 20% have a psychotic disorder. And so you see in some particular way, we're back to where we started, with major levels of population who need mental health care back incarcerated where they were in 1830.
Now, this visualization began kind of, we were talking about creating the bridge, the system that creates the bridge between these 2 previously separate fields of mental health and schools. But as we started looking at the visualization, our concern is that it could also become a circle, taking us back to where we began. But also, we want you to consider this, that really these policies are creating student mobility. So if we look at this, in terms of the students during these periods of time, in the beginning of Jack's story, disabled children were not in schools. They were primarily homed, or they were in churches or garages or converted spaces of some sort. In 1948, and then extending through the 50s and 60s, the BOCES system was designed to serve primarily rural schools, to create for rural schools the advantages that were existing in urban areas. And while the process was unfolding in the mental health system, moving from hospitals, institutions, and home into community-based programs, the children began to move as well. And they began to move primarily into BOCES programs. And then, as the deinstitutionalization really hit its high point, federal legislation changes the domain of dealing with handicapped children. 94-142 is passed, and the concept is introduced to our conversation that in fact, these children and their parents have rights. That has changed immensely the playing field for us as educators. And then we moved from the BOCES centers being the primary providers to the model of inclusion. Children coming back to their community schools, being educated with the children on their street, having the same access to a full range of program, not the mainstream push-in, pull-out model, but really being in classrooms with their peers. That has come along with a whole range of difficulties for teachers and principals and parents and culture. But it is, in fact, our present. Not causally related, but simultaneously occurring, has been an increase of violence in our schools. And those two things really have begun to shift the climate, the cultures that children in our schools are experiencing. Now, certainly add to that dynamic a whole nother context about changes in society, about changes in technology, about access to the internet. All of these things are contributing to this, but it's happening simultaneously. And so we hold the question, are we really going to come full circle? The three largest mental health providers in the nation today are jails. Cook County, Illinois, Los Angeles County, and Rikers Island. To Jack's point, we are a society that hasn't yet figured out how to deal with disability, mental illness. And so those children that probably need the greatest support, the greatest stability, are in fact being moved as policy changes. And generations of them are having different educational experiences because of policy changes. It's been going on now for at least 60 years. Both systems, both the mental health system and the school system, are trapped in regulation, constrained by, but trapped in. It establishes those impermeable boundaries that prevent us from working across systems. Both systems are under demand stress, meaning there is more need, higher standards, more accountability in both systems. Both are resource poor. And both are existing in moments of fiscal crisis. There's a debate going on now about whether to eliminate another 300 plus beds and create services in the community. Well, that's the piece that hasn't come. So leaders, like yourselves, in both systems, often also feel as if we are shackled, as if we are in handcuffs, as we look at the issue from the systemic level. This is not a problem of schools. It is not a problem of mental health. This is, in fact, a societal problem. It's a community problem. It is an educational problem, and it is a mental health problem. And I'm here today because it has also become an urgent problem. School violence is raising our awareness to new levels. And while policy debates go on, the lives of all of us in schools have been changed by the violence that has occurred, hopefully not in this region, but in places that look like us. This is not an urban issue any longer. This is an urgent issue for all of us. And what we know is this. Adam Lanza was a young man who grew up affluently in Connecticut. His mom took him out of school and homeschooled him, when in fact his difficulties in school were becoming so great that it was uncomfortable for him and impossible in the school setting. He stopped going. And over those 3 years, he became increasingly invisible in the community. We all know that Mom and he shared a love of guns and regularly went to rifle range. But the issues of Adam Lanza developing in this home in Connecticut played out there one December morning when Adam Lanza killed his mom. But it played out here as well. It played out on a winter morning in Sandy Hook Elementary. Because these children, these young adults, who frequently become school shooters, have learned how different they are, have learned that they don't fit in, primarily in our schools. So I don't think we should necessarily be surprised when they bring their violence and their anger back to us, as he did that morning. We've thought that we could deal with violence at the level of bullying. Certainly we know the data here. Half the children in the country report that they're bullied or cyberbullied every day. They've got this experience, and 160,000 of them don't go to school because of it. And so we have character education programs, and we have Dignity for All Acts, hoping to change and impact that climate and culture level, hoping to touch on societal values that create cultures where mean girls are the ones that are emulated, and hazing is an acceptable rite of entry. So we're dealing with bullying at that level. Jerry used an underneath story when he, in his introductory remarks. Well, in fact, this issue of mental illness is the underneath story. 1 in 4 Americans suffer a diagnosable mental illness in any given year. 1 in 4. In any year. 60% of people with mental health issues do not receive treatment. One of the common denominators among the school shooters, either on medication or they're stopped taking their medication, or they never were on medication. They're not receiving treatment. And childhood mental illnesses affect up to 1 in 5 children between the ages of 3 and 17 and cost $247 billion a year. Medical bills, special education, and justice. So I've come here because of that December morning, when 20 children, 6 adults, and Adam Lanza all lost their lives at Sandy Hook Elementary School. Since December 14th, 2012, there have been 44 other school shootings in this country. 28 of them in K-12 schools. In many of them, the shooters also die. either by self-inflicted gunshot wound or by police. This isn't any longer the remote headline story. It isn't an urban issue. It is a rural and suburban issue as well. So I will tell you a little bit of Dawn's story. I met her in August of 2012. She was a principal in Connecticut. She called to find out about the doctoral program. And in our phone conversation, she wanted to know about whether it was a rigorous program. She wanted to know what kind of research she would be able to conduct. She wanted to know if it was a program that you could do if you were practicing administrator. And I realized 20 minutes in that she was interviewing me about the program. That was part of who Dawn was. She wanted it to be the best program for her. She and her relatively new husband were building a home on the Sacandaga. It's where they thought they were going to retire together. And so she could see herself spending summers here and coming to the doctoral program in the summer. She was admitted and she entered the program. 2 months later, the people in the cohort with her would say to you, she wasn't one of us, she was the best of us. She was an educator at her core. She was a grandma. And she was about to be mother of the bride at her next daughter's wedding. And she got up that December morning, like many of you did yesterday and will tomorrow. She said goodbye to her husband. She said to her younger daughter, be safe, as she did every day. And on her way into the building, she called her mom. On her mind, the meetings that she had and the holiday concert that was going to be that evening. She went into her office, and in a conference room next to her office, some of you will have one of those, she and her school psychologist and others started an early morning meeting when Adam Lanza shot his way through the locked door into the building. She and Mary, her psychologist, ran from that meeting into the hallway and looked into the face of this heavily armed man. And none of us are surprised that she ran toward him to protect those children, and she was the first one shot. As we heard that the shooting was in Newtown, and we knew that that's where she was a principal, the awful truth unfolded over that Friday. And so her family and Sage came together to say, what good can come from this terrible loss? And in Dawn's way, we decided that we would create a center that would hold both things. Hold mental illness, because indeed Adam Lanza was. And hold school safety, because it is, in fact, the way in which she gave her life. So the Dawn Lafferty Hochsprung Center for the Promotion of Mental Health and School Safety will explore, develop, and share solutions that support the mental health of each child and safe school environments to maximize the opportunities for teaching and learning. We are in our infancy. We are holding those two issues as our motives. We will be exploring, we will be developing, and we will be sharing. We are not going to become program providers. We're going to become a resource for all within schools, within mental health, and within advocacy groups and justice systems who hope to know where to go. Is anyone else doing this? Do you know anyone who would come and work with me if I wanted to do this? That's going to be our function. I'm going to give you a couple of examples. Parsons is developing a mental health clinic in one of Ballston Spa's elementary schools. We're partnering in the establishment of that program. We're tracking what is going on in Massachusetts as the governor embarks a task force to investigate how do we make schools secure, physical plant issues, and what kind of resources are necessary for that. A 6-month project. We are looking at research and supporting research around the issues of mental health and school safety. And on May 30th this year, we are going to have our first summit on the issues of mental illness and school safety. But beneath all of this, there are children. And today we're going to introduce you to Kenny.
In preparing for the talk today, I started by going back and pulling the most recent 75 child files that I've consulted on out. And lo and behold, the first one I came to was Kenny. And so I thought that this was fortuitous, and so I'm presenting to you Kenny this morning. Kenny is a 15-year-old who was referred to me through the PINS unit in the Department of Social Services in a rural county. He had come to PINS as a referral from the school because in school he was utilizing obscene language to the staff. He was making threats of physical violence to the school staff, and he was throwing chairs into people. He had already had an IEP. In the past, he had twice previously been referred to PINS and had gone through the PINS process. He also had been worked up in some ways. He had had 6 previous mental health therapists. He had had previous medication with psychostimulants, which resulted in dysphoric side effects, particularly when they wore off. He rejected all medication. He now is not in treatment, and he's taking no medication. And so I came to see him and met with him and his mother. We learned that at home, during the week he was interviewed, he'd thrown a hammer at mother's head. The police have frequently been called to the home to deal with physical violence going on, particularly between him and his 2 older brothers. The 2 older brothers are currently both incarcerated. Each has a diagnosis of bipolar disorder and of substance abuse. Currently, his symptoms are those of agitation. He has significant sleep disturbance. He shared with me that he takes 4 showers a day in order to get rid of the dirt, as he called it. He has significant compromises in terms of his self-esteem. His judgment is frequently impaired, and he has a high level of risk-taking. In speaking with the family, the mother currently has a diagnosis of bipolar disorder and post-traumatic stress disorder, and she remains in treatment. She has had her arm broken by a former paramour, who actually is the biological father of Kenny. He had held the family in some confined situation for a long stretch of time, and obviously Kenny had witnessed this domestic violence within the home. He also was subject to significant bullying and physical harassment by his brothers, and he himself has considerable symptoms of post-traumatic stress disorder with numbing and hyperarousal and the re-experiencing which goes along with that disorder. He has a biological father who has a history of alcoholism and numerous DWIs, and the family court imposed orders of protection, preventing him from seeing Kenny. Kenny, with this rupture of the relationship, came to idealize his father, and has very intense rage that he is prevented from having any contact with the father. So, this is the clinical situation. I think we know well that the risks here are very substantial. I'm sure that there are pennies in every single one of your school districts. And so, looking through the record and all the reports, pretty reasonable workups had gone on. The boy had been referred to an audiologist who had confirmed that there were elements of central auditory processing problems in terms of his language understandings. He does have some strengths, and those were noteworthy. He has some insight into how his anger is a danger to him and needs work. The record was missing any functional behavioral assessment, and that's obviously something that needed to have been compiled within the school in order to properly address this aggression which is occurring there. We have a couple of ways of approaching this. Number one, we need to have a categorical diagnosis. This is what you see in DSM-5. And obviously this boy has comorbid conditions. He has had previous diagnosis of intermittent explosive disorder, ADHD, post-traumatic stress disorder, obsessive compulsive disorder, and the central auditory processing problems about which I spoke. In attempting to understand all of this, one has to approach the evaluation in terms of understanding what is going on biologically. This child obviously is predisposed to having, from a genetic standpoint, bipolar disorder. Two siblings and the mother reportedly have bipolar disorder. There are significant genetic ramifications to this. And he's already been diagnosed as having attention deficit hyperactivity disorder, and there are obviously biological underpinnings to it, as well as to the CAD, central auditory processing disorder. And looking at the psychological ramifications here, he's had exposure to domestic violence. He has significant anxiety that's come out of all of that. This has profoundly influenced his own identity. He acknowledged that he was a bully to other kids in school, and obviously he's been bullied. He does have some significant insight, which is certainly a strength of the. And one needs to also look at the social and cultural influences here. Growing up in an environment that was filled with trauma. Obviously, he moved from school district to school district, and the ramifications of that are well documented even in the recent psychiatric literature. In the family, he has major confusion and rage regarding issues about his paternity. He was previously indulged, but at the same time, obviously, understimulating in a positive manner. Lies and deceptions have permeated the system, and so obviously he doesn't know really what is reality. And I have to say that the biggest risk here for Kenny, besides this violence that is undergoing, is the whole risk of substance abuse, which will only fuel the flames of what's actually currently happening. There's another way of looking at the aggression beyond the categorical process, and that's looking at it in a dimensional standpoint. What are the causes of the aggression? Can we get closer to the biological roots of where this is all coming from, and what does it look like? And in looking at this, we can divide this up into certain different categories. The first is the impulsive one. This is the one in which the child can't play. There is no pulling back to consider what might be the risks of blasting off with some physical or verbal response. These are connected to different areas of the brain, particularly the impulsive one, the ventral medial portion of the frontal lobe, and we can go through and identify those parts for these other different dimensional aspects of aggression, but I won't go through that relative to our lack of time. The next form is an affective instability. This would run along with any mood disorder, bipolar, depressive, whatever, and obviously the boy has a setup for that. It's connected to emotional dysregulation. Next, we have the anxiety hyperarousal part. This has to do with both OCD here, this need to go through rituals in order to contain the anxiety, as well as into the hyperarousal part, which gets connected to the alterations in your hormones through the hypothalamic pituitary axis. Next comes predatory aggression, and this is the type of aggression that is thought about ahead of time. A prototype might be a drug lord deciding to put down someone who's obstructing the plan. And finally, a cognitive disorganization piece. This comes when you're in the midst of a full-blown psychotic diathesis, one in which there are hallucinations and delusions. It's contributed to by being in the midst of significant substance abuse, which alters perceptions of reality. It comes with paranoia. It comes with brain injury. And we know that, at least in many of the recent shootings, the shooters were totally psychotic. We know in the Texas, University of Texas Tower shooting that the shooter had a very significantly sized brain tumor. So one needs to really look through all of these things in order to make a comprehensive assessment in order to come together to make an effective treatment program. That's the next slide.
So Kenny is our story. There are so many variations of Kenny in our classrooms and in our schools and in our clinics. And so our sense is that what Kenny needs is around him a delivery system of related parts. Not disjointed parts, but related parts. And Jack's sharing of Kenny's story is not probably the story that would have been shared by Kenny's classroom teacher. That would have been a very different story. And yet, they are together Kenny's story. So a comprehensive evaluation, partnerships for delivery, because the pieces of Kenny's story, as we know him now, cannot be dealt with in a school environment. Well, let me rephrase that. It cannot be dealt with by educators. We need people who are, in fact, mental health professionals to help us deal with Kenny.
And I would say that the establishment of these partnerships is not easy. The teams are fragile at times. And I think if we went through the audience today and I were to scratch just a few issues, we immediately come up with conflict regarding attitudes on several different subjects. And this involves not just here, but even within one discipline. We have to remember here, these are very discrete disciplines: social work, psychology, medicine, education, and each of them has a totally different language. So just coming to deal with the language differences is one problem. But then if we come to look at the use of restraints, the use of medication, the issues regarding implementation of zero tolerance, whatever that means, and the impact of that on both mental health as well as educational formations, we don't have to imagine that we have some conflict here pretty quickly.
One of Kenny's advantages is that there was still family support involved. And regardless of the quality of it, there was still presence of it. And they were willing to work within the system, or at least Mom was. Whereas in Adam Lanza's case, Mom had given up and Dad was gone. So yes, indeed, for all the multiple times we have said, oh, family was only supportive. Family is important as a part of this design. So, however, is creativity and flexibility, and I think I would even add persistence. Because the complexities of trying to resolve Kenny's issues and create an educational and mental health environment in which Kenny can become productive and happy, in fact, takes persistence. It is easy to give up, to become frustrated by the barriers, and so creativity, flexibility, and persistence. But as I told you, we have a perspective of the value of rural schools, and we want to wrap back to that. Rural school advantages. One is community. It's difficult for children to become invisible in rural communities. It's not so often that you don't know who's down the road. That's a real advantage. Size is also an advantage, and most often we hear about that as a disadvantage. But from this perspective, we contend that size is an advantage. Because the community of children know each other, and in fact, probably the community of faculty know more of the student population than just those who are coming to them. And in some cases, there are teachers who have all of them. So the knowledge system that's working in rural schools is an advantage. From the perspective of our future partners, those who are coming from other agencies and can help us add this mental health support ingredient, the maneuverability within rural schools is also an advantage. There are stories about dealing with the complexity and the bureaucracy of larger systems. Rural schools don't have that complexity, and they're not embedded in that bureaucracy. It's pretty much, we're there, and this is who we are, and we're doing a lot of the functions that in more complex systems are divided up among many players. That's an advantage to us finding partners. The other advantage is we learned long ago that we don't have the resources to do it all, that we are isolated from services, and from the perspective of our future partners, that makes us more receptive. These can be disadvantages, but we would suggest to you that in dealing with these issues, these are advantages. Also, there's research coming out of MIT that deals with every change should exist in a prototype before you change policy and inflict it on everyone. Some of you might even feel that way about other changes that are happening in the educational world. But we think that rural schools at this point in time, as you begin to explore the options and consider the kinds of things that Jane's going to talk to you about in a minute, we have the opportunity here to prototype, to establish those small centers that in fact can eventually demonstrate at the policy level what is possible and what is needed. There was another shooting in DeKalb County, Georgia, but it didn't have tragedy associated with it. Because, in fact, there was a woman in the office working that morning who talked this heavily armed 20-year-old, put down his weapon, Her name was Annette Tuff. She has now written a book and she's on the speaker's circuit. And her story is this: I was put in that office for a purpose. I called him sweetheart. I told him it would be okay. He put down his gun. Not that that would happen in every situation, but it happened in this situation. And she contends that love made the difference. You have a story from your colleague? No?
Why don't we start there? We'll stop here.
You want to tell your other story?
No.
Okay, I want to do one other thing. Annette would say it was love. Dawn would say it was kindness. And while love and kindness frequently don't impact policy level thinking, they do impact our connection with children every day. And after all, children are at the heart of the matter. Now we're stopping really, Jay?
Yes.
Okay, we're done. Thank you.